Hello everyone. Today I am going to discuss about the case study which I had posted in last video. So the probable diagnosis was classical phenylketonuria. Phenylketonuria. So I am going to discuss about this inborn error of amino acid metabolism, that is classical phenylketonuria, and in between I will be answering the questions which I had asked in the previous video. So the today discussion would be regarding classical phenylketonuria. So you know that this classical phenylketonuria is a inborn error of amino acid metabolism, and basically that happens due to mutation in the gene coding for the enzyme called phenylalanine hydroxylase. So there are different types of phenylketonuria. So we have the most common type is classical phenylketonuria, and other one are called non-classical phenylketonuria, or we can call classical phenylketonuria as PKU1, phenylketonuria type 1. So there are basically 5 types. So classical phenylketonuria comes under PKU1, that is type 1 phenylketonuria, and other types are called non-classical phenylketonuria. That includes PKU type 2, type 3, type 4 and type 5. So basically there are 5 types of phenylketonuria. Under classical phenylketonuria we have phenylketonuria type 1, and that happens due to mutation in the gene coding for the enzyme called phenylalanine hydroxylase. Okay, and that gene for phenylalanine hydroxylase is present on the chromosome number 12. Okay, so basically it is an autosomal recessive disorder, and if both the defective copy of the gene are inherited from the parents, this disease called classical phenylketonuria happens. Okay, and remember, it is the most common inborn error of amino acid metabolism. So you should remember this. So basically we look into the different introduction part of this classical phenylketonuria. So you should remember this. This is there are basically 5 types of phenylketonuria. That is the first point. Classical phenylketonuria, that is PKU1. Classical phenylketonuria is most common inborn error of amino acid metabolism. So this is the most important point. So basically there are 5 types of phenylketonuria. So these basically that is divided into 2 groups, that is classical phenylketonuria and non-classical phenylketonuria. Under classical phenylketonuria we have type 1 phenylketonuria that happens due to mutation in the gene coding for the enzyme called phenylalanine hydroxylase, and non-classical phenylketonuria happens due to there is a defect in the enzyme called dihydrobiopterin reductase, or if there is a defect in the synthesis of tetrahydrobiopterin. So there we can develop non-classical phenylketonuria. So today we look into the classical phenylketonuria, or we call it as a PKU1. Okay, so as I told you, PKU1 is the most common inborn error of amino acid metabolism, and it happens due to mutation in the gene coding for the enzyme phenylalanine hydroxylase. So this is the defect. Which enzyme is defective? This is the important point we should remember. Phenylalanine hydroxylase is defective. So this is the defective enzyme in case of classical phenylketonuria or PKU1. So this is the main defective enzyme, and it is an autosomal recessive disorder. Autosomal recessive disorder. So it is an autosomal recessive disorder, means the gene which code for phenylalanine hydroxylase is present on the chromosome number 12. If both the gene get defective from if some person inherit both the defective copy either from both from mother and father, then only this classical phenylketonuria will happen. Okay, otherwise it won't happen. The mode of inheritance is autosomal recessive, that you should remember. Now coming to how this disease progresses. So first we look into the normal catalytic activity of this phenylalanine hydroxylase. What does this phenylalanine hydroxylase do? So phenylalanine hydroxylase is involved in conversion of phenylalanine in the presence of PAH, that is phenylalanine hydroxylase, that requires tetrahydrobiopterin as a cofactor, and this is converted into dihydrobiopterin, and this is interconvertible. So this, with the help of this phenylalanine hydroxylase and this cofactor called tetrahydrobiopterin, phenylalanine is converted into one amino acid called tyrosine. Okay, so phenylalanine is converted into tyrosine. That is the main non-essential amino acid which is synthesized from phenylalanine. So if there is classical phenylketonuria, what will happen? There will be deficiency of this enzyme called phenylalanine hydroxylase, which convert phenylalanine into tyrosine. So what will happen? Phenylalanine level in blood will increase, tyrosine level will be reduced, and obviously due to increased level of phenylalanine in blood, there will be different signs and symptoms. Basically, we see profound intellectual disability in the children of children suffering from classical phenylketonuria. So now we look into the detail how this elevated level of phenylalanine in blood will responsible for the sign and symptoms. Okay, so now we'll look into the clinical presentation of the disease, or clinical presentation in case of classical phenylketonuria. Now we look into the sign and symptoms associated with phenylketonuria. So remember this, here there is a deficiency of enzyme phenylalanine hydroxylase. So obviously phenylalanine from phenylalanine tyrosine won't be there won't be formation of tyrosine from phenylalanine. So obviously phenylalanine level in blood will increase and tyrosine level in blood will reduce. So now we look into the clinical presentation of PK. Clinical presentation of PKU1, that is phenylketonuria type 1, or we call it as a classical phenylketonuria. So remember, at birth child is completely normal. Okay, there is no sign and symptoms at all. So child is normal at birth, but as phenylalanine rich diet is introduced, like milk have high level of phenylalanine, sign and symptoms start appearing gradually. And remember, this inborn error called phenylketonuria is treatable if it is diagnosed at early stage. So if the diagnosis is delayed, or due to some reason diagnosis was not made, so gradually sign and symptoms will start appearing, and there will be gradually profound intellectual disability which will be seen in the child. So the first sign and symptom which will come is vomiting. There is a profound prolonged vomiting, something that can be misdiagnosed as pyloric stenosis. Okay, pyloric stenosis is associated with severe bouts of vomiting or severe vomiting. Like that only can also be seen in case of phenylketonuria. So there will be severe vomiting, and that sign and symptom will be gradual. Okay, it won't appear suddenly. There will be gradually, there will be appearance of sign and symptoms if it is not treated. Okay, and if there is a delay in diagnosis. So as child ages, or as child gets older, sign and symptoms start becoming more and more severe, and they will appear gradually. So there will be the first sign which will come is vomiting. Then there could be due to that delay in treatment, it can lead to, there will be also delay in developmental milestones. So there will be delayed developmental milestone. There will be microcephaly. Microcephaly means head size will be smaller. Microcephaly. That is also one of the signs which we see, or clinical presentation of classical phenylketonuria. So what did we see? There will be vomiting, and vomiting will be very severe, something like pyloric stenosis. There could be profound intellectual disability which will appear gradually, including that there will be delayed developmental milestones, and after that, and there could be microcephaly, that will be small head size will be seen, and later on, if the child remain untreated for longer duration, that can develop, there could be development of seizure, or seizure can induce convulsion also. So in case study I had discussed about it, there was presence of convulsion. It can lead to hyperactive behavior. So there will be, child will be hyperactive, okay, and there will be, the child will have, that untreated older child will have purposeless hand movement, okay. There will be purposeless hand movement, there will be rhythmic rocking. So there will be purposeless hand movement, there will be rhythmic rocking. Rhythmic rocking means what? The child will have, there will be, some activity like, continuous banging of head. The child will do repetitive behaviors. Repetitive behavior will be seen, and that there will be also presence of, abnormal movement that we call athesstosis. Athesstosis is also seen. That is, there is an involuntary movement of limbs like hand or leg or even fingers, that is called athesstosis. So as the child grows older, and if treatment is not started at right time, so the signs and symptoms will become more and more severe. That is the most important point you should remember. So it can be present in the form of severe vomiting, starting from microcephaly. There could be, there could be delayed developmental milestone. There could be, seizures. That will be, seizures can lead to, convulsion, attack of convulsion. There could be, hyperactivity. There could be, purposeless hand movement. There could be, rhythmic rocking, like something like continuous banging of head. And there could be athesstosis, that is involuntary movement of the limb, including, fingers and all. So these are the signs and symptoms, and it can also cause mental retardation. Mental retardation means that IQ level will be very low. So as I had discussed in previous case study, in the last video, I had told about this symptom called, mental retardation. Apart from that, there is, there is a hypopigmentation. Hypopigmentation means there will be decreased melanin synthesis, and due to decreased melanin synthesis, there will be, light color hair and skin. So the skin color will be fair, hair color will be gray. So that is due to hypopigmentation. That will be due to reduced melanin synthesis. Even eye color can be blue due to hypopigmentation, and that is due to reduced melanin synthesis in those individuals. So that is also very prominent finding which we see. Apart from that, there could be, mousy or musty body odor. So that is also one of the peculiar findings which we see in classical phenylketonuria patients. So there could be mousy odor, mousy smell, or musty smell in the body of the patient, or even in the urine also that smell can be felt. So that is the main findings which we associate with, phenylketonuria. Now coming to the biochemical basis of the, sign and symptoms of the clinical presentation which we see in case of phenylketonuria. So now you know that since this phenylalanine is not getting converted into tyrosine, so what will happen? This phenylalanine is not getting converted into tyrosine, or tyrosine or very less amount of phenylalanine will be converted into tyrosine due to deficiency of enzyme phenylalanine hydroxylase. So phenylalanine level in blood will increase, and this phenylalanine, with the help of transporter called called large neutral acid transporter, large neutral amino acid transporter type 1, it can cross the blood brain barrier. So this is blood brain barrier, and it will enter the brain. And this, remember, this phenylalanine is highly toxic, because here phenylalanine amount in blood will increase at very higher amount. Okay, so phenylalanine level will be very high. So obviously more amount of phenylalanine will enter from blood by passing this blood brain barrier with the help of this transporter called large neutral amino acid transporter type 1, and it will enter brain, and there this phenylalanine will accumulate, and this will cause severe neurotoxicity. That's why the neurological signs and symptoms like vomiting, seizure, or mental retardation, or purposeless movement of hand, ATHESTOSIS, all those things are seen. The neurological signs and symptoms are basically due to what? The first reason being excess accumulation of phenylalanine in brain, and that phenylalanine is coming from blood itself, because that blood brain barrier had this transporter called large neutral amino acid transporter, and more amount of phenylalanine will enter from blood to brain, and it will start getting deposited and causing neurological signs and symptoms. So the question I had asked was, what was the biochemical basis of neurological signs and symptoms? The answer being excess level of phenylalanine in blood can cause neurotoxicity. Apart from that, the second reason for neurological signs and symptoms or neurological manifestation which we see in classical phenylketonuria is due to this excess level of phenylalanine in blood, and obviously this large neutral amino acid transporter type 1 transports other amino acid also, like other large neutral amino acid like tryptophan or valine or leucine. So these all large neutral amino acid including tyrosine, these have same type of transporter called large neutral amino acid transporter type 1. So phenylalanine also uses the same transporter as tryptophan, tyrosine, valine or leucine. So what will happen? This phenylalanine, this transporter called large neutral amino acid transporter type 1 will get saturated due to increased level of phenylalanine in blood. So obviously this increased level of phenylalanine will compete with this large amino acid like tyrosine, tryptophan, valine, leucine for transport across the blood brain barrier. So it won't allow the transport of these amino acid like tryptophan or tyrosine, whatever tyrosine, small amount of tyrosine which is being synthesized into brain because of increased excess level of this phenylalanine, and this because that this transport system gets saturated with phenylalanine, so it won't allow other amino acid transport across the blood brain barrier. So obviously, so there will be lack of tryptophan, lack of tyrosine, whatever tyrosine being synthesized inside brain, and that tyrosine is required, and on the top of that you remember this, there is a deficiency of tyrosine here because phenylalanine is not getting converted into tyrosine. So tyrosine is used to synthesize various important products in our brain, that is catecholamines like epinephrine, norepinephrine, dopamine. So their amount in brain will decrease because tyrosine amount is less, tyrosine availability is less, and on top of that this large neutral amino acid transporter has got saturated. So obviously in that case what will happen? This tryptophan amount in brain will decrease, tyrosine amount in brain will decrease, and this tryptophan is used to synthesize serotonin. That is also one of the important products which is synthesized, and this tyrosine is helpful in the synthesis of, or it serves as a precursor for the synthesis of catecholamines like epinephrine, norepinephrine, dopamine. So their level will also go down, and because of reduced level of catecholamines, dopamine, serotonin, again that will lead to, that could be one of the probable cause of neurological signs and symptoms which we see in phenylketonuria patients. So remember this, neurological signs and symptoms in phenylketonuria is seen due to what? Excess level of phenylalanine in brain, and as well as reduced level of catecholamines dopamine and serotonin inside brain. Okay, so that is the two reason or the basis of neurological manifestation. What is the cause of hypopigmentation? So you remember this tyrosine is used to synthesize so many products. As I told you, epinephrine, norepinephrine, dopamine and synthesize. Tyrosine is also used to synthesize melanin. That is one of the pigments which is present in skin, hair, eyes. So the melanin, due to lack of enzyme called phenylalanine hydroxylase, this melanin level will reduce. Obviously, this because phenylalanine is not getting converted into tyrosine, or there will be very less amount of tyrosine available. So what will happen? The melanin level that is responsible for the pigmentation of our skin, hair, our eyes. So that melanin level will decrease, and that will lead to what? Fair color skin, fair color hair. There will be light color skin, light color hair, or blue color eye. That is also one of the findings which we see in phenylketonuria patient. And what is the reason for MOUSEY order? What is the basis of MOUSEY order of the body or MOUSEY order of the urine? So since phenylalanine is not getting converted into tyrosine, or very less amount is getting converted into tyrosine, so this phenylalanine will take alternate route. So this phenylalanine will be undergo transamination to form phenyl pyruvate. And this phenyl pyruvate can get reduced to form what? Phenyl lactate. Phenyl lactate. And this phenyl pyruvate can also undergo decarboxylation to form phenyl acetate. So all these precursors and this phenyl acetate can further combine with glutamine to form what? Phenyl acetyl glutamine. Phenyl acetyl glutamine. So what will happen? Obviously phenylalanine level is high, so this phenyl pyruvate level will also increase, phenyl lactate will also increase, phenyl acetate will also increase. So you can see this phenyl pyruvate and phenyl acetate are phenyl ketones. That's why the name phenylketonuria has come from because of appearance of phenyl pyruvate and phenyl acetate in urine, and these are called phenylketones, and that's why it is called phenylketonuria. So there will be increased appearance of phenyl pyruvate and phenyl acetate in urine. Okay, and this phenyl pyruvate and phenyl acetate, obviously this phenyl acetate has property of giving MOUSEY order to the body or MOUSEY order to urine. So that's why due to excess production of phenyl acetate in the body, obviously there will be MOUSEY or musty order of the body or urine. Okay, so there will be increased appearance of phenyl pyruvate, phenyl acetate, phenyl acetyl glutamine in urine. Okay, first it will increase in blood and then it will come in urine, and obviously due to this phenyl acetate there will be musty or MOUSEY order. So the biochemical basis for the musty and MOUSEY order is due to there will be alternate pathway which gets active. This phenylalanine will take alternate route and it will be converted into phenyl pyruvate, phenyl lactate, phenyl acetate and phenyl acetyl glutamine, and this phenyl acetate is responsible for the appearance is responsible for the MOUSEY order of the urine. So remember this point, and we can detect, if diagnosis part is concerned, we can detect phenyl ketones by using this ferric chloride test. So once we perform ferric chloride test with urine, that will give a transient bluish green color with the urine. So the question was, what ferric chloride test will be if ferric chloride test is done, what will be the result? So in this case, in case of phenylketonuria, if we take urine sample of the patient and if we do the test, there will be appearance of transient bluish green color due to presence of phenyl pyruvate. Okay, this is a phenyl ketone which comes in urine. So I hope the concept is clear. In next video I will be uploading the diagnosis and the treatment part of classical phenylketonuria. So thank you all for joining.